Going live in 5, 4, 3, 2, 1. We are live now.
Good evening, everyone. Welcome to the platform of Orthopedic Research and Education Foundation India. Today we have our faculty, Dr. Ratnesh Singh sir, who is teaching us about Unicondylar knee arthroplasty. Ratnesh sir is a consultant in Paras HMRI Hospital, Patna, and has done lots of these type of cases. So over to you, sir. John sir will join in a few minutes.
Yeah, good evening, everyone. Today I shall discuss more about the unicondylar knee arthroplasty, which are becoming the trend now, and many of the cases of total hip replacement can actually be total knee replacement can actually be managed with the unicondylar knee. First, Albach in 1969 reported that 85% of osteoarthritis.
Excuse me, sir.
Yeah.
It is still the first slide and it is not full screen yet.
I can see here full screen.
So, you can just, I think you can, yeah, now we can see, but full screen you can make it, yes.
Is it
it's
full
not
screen now?
No, sir.
I can see full screen here.
Maybe although it is very clear, sir, but if it is possible.
Sir, you can keep the full screen and then you can share the screen. Now you can stop sharing, and after keeping the full screen on another tab, you can select the full screen tab.
Now can you see it full screen?
Still coming. Dr. Ratnesh Singh has started screen sharing, so probably. So you just try once more. Yes, sir.
Can you see full screen now?
So it's okay, sir. Otherwise, it's very clear. So we can send like this mode also.
I'm seeing full screen here.
Maybe, sir, some something we are missing, but still it is very clear, sir. So you can go ahead with this.
Still, it is not full screen.
No, sir.
Okay.
It is very clear, sir. So you can start the lectures.
Okay. Albach in 1969 reported that 85% of osteoarthritis is confined to medial compartment and can be managed with medial compartment replacement only. So the first Oxford knee prosthesis, which was designed by John Goodfellow, it was introduced in 1979 as a bicondylar replacement, with keeping both the ligaments intact, ACL, PCL, and trying to replicate the normal knee. It was initially designed for osteoarthritis and rheumatoid arthritis cases, but over the time it has been shown that the absent or severely damaged ACL at the time of surgery was an important determinant for an early implant failure. So if the ACL was intact, the osteoarthritis was limited to medial compartment of the joint only. And when there was no ACL, the osteoarthritis was more common in bicondylar. This pattern of disease was later more formally described as anteromedial osteoarthritis of the knee, and came to the consideration of primary indication for the use of mobile bearing prosthesis as the medial unicompartmental replacement. So the only indication what we do still in current days, we are doing the uni knee for anteromedial osteoarthritis only when there is erosion of the posterior condyle. The total knee is preferred. Now coming to the UKA, it should be the first procedure for osteoarthritis in younger patient when there is involvement of in younger patient. Usually the ACL is functional, and in early osteoarthritis there is usually the erosion is in the anterior part of the medial condyle. Unicondylar knee can be done in all the three compartments. That could be either medial compartment osteoarthritis or medial compartment replacement. In lateral compartment, you can do the lateral compartment replacement, or you can do the patellofemoral. You can do for the patellofemoral osteoarthritis. Independent patellofemoral component is also available. That compartment can also be replaced. But for all practical purposes, the medial compartment osteoarthritis or medial compartment replacement is considered nowadays as unicompartmental replacement. Other compartments are replaced very rarely. So we can do the unicompartment or medial compartment replacement in 5 to 10% of TKR, what we are doing nowadays. So what is the advantage of unicondylar over total knee? First, it has faster rehabilitation and quicker recovery. We preserve the joint proprioception as the ligaments are intact. Shorter hospital stay, less morbidity, less expensive. It has lower rate of prosthetic joint infection, about 70% less than the infection rate in total knee. The UK has 70% less rate of infection, and other known complications like pulmonary embolism and other complications are also very less.
Excuse me, sir.
Yeah.
So, the slide is not changing. So can you just try it once more?
Which slide is there?
Sir, introduction. Yes, sir. Perfect. Now it's full screen also.
Yeah.
Yes,
Are you able to see the full screen?
yes sir. It's
Pages
very
are
clear.
changing also?
Yes, sir.
Yeah. So coming to the advantages, this UK has a much lower rate of prosthetic joint infection and wound complications as compared to the total knee replacement. Here we preserve the normal kinematics of the knee. We are retaining the ACL, PCL, other ligaments and compartment whose lateral and patellofemoral is also preserved. So it leads to more normal knee kinematics. Incision is small, so there is less post-operative pain and less blood loss. So coming to the classical indication for the TK UK, although the indication has been broadened a lot in these days, the classical indications are age 55 years or older, varus or valgus deformity should be less than 5 degree. If it is more than 5 degree, that should be correctable. We need the intact cruciate and collateral ligaments. BMI should be less than 30. In opposite compartment, meniscus must be intact. Suppose we are doing the medial one, the lateral compartment, the meniscus must be intact. Slight fibrillation or mild chondrocalcinosis is acceptable. It is not a contraindication. Articular cartilage, the opposite compartment must be intact and superficial fibrillation is acceptable. Traction contracture should be less than 10 degrees. The absolute contraindications are inflammatory arthritis, ACL deficient knee, fixed varus deformity more than 10 degrees, fixed valgus deformity more than 5 degrees, restricted motion arc less than 90 degrees, traction contracture more than 5 to 10 degrees, previous meniscectomy in other compartment or in tri-compartment arthritis, young high active patients and heavy laborers, and grade 4 patellofemoral chondrosis. These are the absolute contraindication. Although in grade 4 patellofemoral chondrosis, we can do the patellofemoral compartment replacement. But if you are doing the only unicompartment for the medial compartment, then it is contraindicated. Now coming to the technique is little bit different from what we do in the total knee. Here ligaments are never released, nor they are lengthened like we do in total knee replacement. Here the ligament balancing is done by bone cuts. So if we see the X-ray, the wear pattern should be anteromedial osteoarthritis as discussed before. But for best result, it should be bone-on-bone arthritis. Means there should be the loss of cartilage from both femur and tibia, and in normal X-rays, you should be able to see bone-on-bone on medial side. Suppose in normal AP view, we are not seeing the osteoarthritis to the grade that bone-on-bone is seen. Then we can check with the varus stress view, or we can do the Rosenberg view to see if bone on bone can be seen. Still we cannot see, and we want to go for the UKA. It is better to go for the arthroscopy to see the raw bone on both femur and tibia. If that is not present, then it will not lead to the pain-free movement. We should look for the other cause of pain also. In lateral view, we should assess the erosion. Where is the erosion is? The erosion should be confined to the anterior and anterior to the middle part, but that should not go beyond the middle one. And the posteromedial tibial bone loss is an indication of deficient ACL or malfunctioning ACL. So these are not the ideal indication for UKA. Coming to the patellofemoral joint, normal or medial facet osteoarthritis with or without bone loss, or lateral facet osteoarthritis with or without bone loss, we can go for the medial compartment replacement. But in cases of lateral facet osteoarthritis with bone loss, grooving and subluxation, This is not the ideal case for middle compartment replacement. Here we can combine with the middle compartment and patellofemoral, or we should go for the total knee. Now coming to the implant design. Implant design is both mobile bearing, which is more common, and earlier the Oxford knee was launched, which has a very good success rate. And then comes the fixed bearing like Sigma knee or the debut Sigma knee. Here the poly is fixed to the tibial component, while it is mobile in Oxford knee, and that gives more or less like a normal knee movement. The implants are available both in cemented and uncemented variant. Now coming to the implant design, mobile bearing UKA. The movement is more natural. The poly is highly conforming. It reduces contact stress. When your implant is highly conforming, it reduces the point stress like that we see in normal TKR or in fixed bearing. Only some part of the implant is in contact with the poly. But in mobile bearing UKA, the implant is highly conforming and less point stress. So it's the less wear. It will lead to less wear, theoretically. Now coming to the fixed bearing implants, it has less conformity, high point contact stress, high wear rate, but the advantage is there is no bearing dislocation. But newer papers suggest that fixed bearing has much better role than the mobile bearing, but we still need to see long-term result of the fixed bearing work. The mobile bearing or Oxford knee has almost 40-50 years of the follow-up, and they are doing quite well. And average life is 15 to 20 years. It's doing very well. Revision rate at 15 years is even up to 10% for the mobile bearing Oxford knee. Now coming to the complication of unicondylar knee, the infection. As I already said, the infection rate is much lower in cases of UKA compared to the TKR. Loosening of tibial or femoral component. It could be the subsidence of the tibial component, which is more common, especially in soft bones, so it is contraindicated in the required one. Polyethylene increased wear, implant failure or fracture, mobile bearing dislocation in cases of Oxford knee, malpositioning and alignment error, instability and ACL deficiency, and patellar impingement. Newer instruments has been designed to prevent this patellar impingement. Now coming to what does the evidence say? UK provide more patient satisfaction than the TK in comparative study, published in CORR 1991. Modern techniques and implant design of UKs lead to less wear. It is 2017 studies. Higher failure rate of UK are associated with centers and surgeon performing low number of procedures. And they also suggest that the expand indication by increasing UKR uses, which can help in lowering the revision rate. This is data published in Bone and Joint Journal in 2015. According to this data, more the number of cases, less is the revision rate. So the UK uses, if you are doing 100 knee arthroplasties, at least 20 UKR for acceptable revision rate. Then UK can be used as an alternative to TK when indicated. Even in our practice, we see 5 to 10% of the cases which could have been done with the UK in place of the TKR. Thank you.
Yes, sir. So, while we are waiting for questions, just two indication what you have told, sir. One is age more than 55 and bone. This thing, the weight should not be more, so it should not be overweight. So is there any change in that one, sir? Like,
Yeah, recent German studies have showed that even the higher BMI, or even if it is done in more active age or earlier age group, the results are quite well. They are quite acceptable. So the indication has been broadened over the time.
sir. And sir, why it is only for anteromedial? Why not posteromedial, sir?
In case of the posteromedial, if the bone loss is posteromedial, then it indicates the ACL deficient knee. In intact ACL, normally the bone loss is in anteromedial part, and that is the indication for it. If ACL is not functioning, it is a contraindication. But for fixed wearing, they are saying that you can even go with the posteromedial defects. With fixed wearing implants now, like DePuy implants, they have broadened the indication, but classical indication is to do in only anteromedial bone defect.
So Rajan Rai has asked what the indication of UKA versus HTO.
UKA and STO both are indicated for osteoarthritis of the knee, especially in the medial compartment. When there is too much virus is present and that virus is doing the osteoarthritis, in that case, STO is better option. When there is not a complete loss of cartilage, STO is the better option. Or in heavy laborers, STO is the better option. But UKA gives the immediate relief, immediate pain relief, very faster rehab, not like in STO, where you have to wait for at least 6 to 8 weeks for returning to the work, first thing. Second thing, pain relief is not as predictable as in UKA or TKR. They are more predictable in replacements rather than in osteotomy group.
And so that about the ACL also we can do with HTO if it is that is ACL deficient knee.
Yeah, in ACL
Here is it.
knee you can go. In ACL deficient knee, even people are doing the ACL with UKA. But the long-term result is yet to wait. But they don't suggest to go with ACL and UKA, middle compartment replacement. They don't suggest, but people are still doing, and long-term result has to be seen over the time.
So one thing during HTO lecture, it was said that for even that patient needs a total knee replacement letter, that is possible easily with the new incision and all. And it is at least for 8 to 10 years, the delay of TKR can be done. In Unicondylar, sir, is it also possible that total knee is easily to be done after the UK?
Yeah, UK has a good survival rate. Even in 15 years, 90% survivorship is around 90%. So if it is doing 15 years, you can delay the TKR for 15 or 20 years, or you are preventing the disease to progress from one compartment to the other compartment. It is good, you are buying time, and even for the failure rates are quite similar to TKR. Means TKR is still gold standard, but failure rates are quite comparable. So in case of only medial compartment osteoarthritis, and the involvement of other compartments is very minimal, you can still go with the unicompartmental replacement. Most important thing is the faster rehab, and second, the proprioception is maintained and the normal kinematics is almost maintained. So patient has very good feeling after UKA, but after TKR, many a patient complains of some joint position sense problem. Some patients say my knee is turning when I'm walking. There are many, this joint position sense is a little bit disturbed and it cannot actually replicate the original knee. Even with the newer implants, the total knee cannot actually replicate the complex movement at knee during flexion extension. But here, mostly it is most of the ligaments are preserved and movements is mostly almost replicated like a normal. So patient satisfaction rate is very high.
So about the rehabilitation, if we can compare it with total knee arthroplasty, is it same or is there any difference in that?
Rehab is very fast. You can start the knee bending up to 90 even from the day 2. Day 1 or day 2, you can start. Patient can walk on the same day. Less incision, less surgical time, less pain. So everything works. Rehab is quite fast.
And about the costs, cost of UK?
Cost in India, it is almost similar, slightly cheaper than total knee implant.
Okay.
But in Western world, it is cheaper. They also calculate the hospital stay and rehab protocols. So for them, it is quite cheap.
So you have mentioned about that patellofemoral arthritis that can also be called as unicondylar knee arthroplasty.
Yeah. We can do the patellofemoral replacement alone also. We can combine the medial compartment with patellofemoral also.
Okay. So compartment wise, sir, is it possible that both the both side on the lateral plateau and the medial plateau simultaneously that UKA can be done? If
it has been done, it was first designed for the bicondylar knee actually.
okay.
So the bicondylar knees are not doing as good as they are expected theoretically.
Yeah.
So they change it to the total knee. But unicondylars are doing, especially the medial compartment is doing quite well.
Yeah, John sir has joined. So, sir, lecture sir has finished.
Okay,
Good evening, sir.
That's fine.
Yes,
I just
sir.
got in, so.
Yes, sir. So, sir was telling about the rehabilitation, that it is quite faster in case of UK if we compare it with total knee.
Yeah, absolutely. I think there are some very selected indications for it where it may have, it has a place for sure. Only thing is it has to be technically done perfectly, otherwise it doesn't work.
So,
Even
one
the
thing,
literature says if you are doing more numbers of unicondylar knees, your result will improve over the time.
Absolutely. So it is a technically demanding procedure which has to be done right for it to work. And but certainly in a certain group of patients who have medial compartment arthritis with fairly, even with a situation where it is bone on bone, if the lateral compartment is reasonable, it's an option that has its place. I mean, you have to weigh the advantages and disadvantages of HTO, but that's a slightly different population group where HTO is better. And you have the middle-aged ladies, the osteoporotic bone, where probably unicompartment knee works better. So
that one question already, although sir has answered about the UK versus HTO indication, because there is slight overlapping.
yeah, there's overlapping, and there will be situations where, depending on the surgeon's preference, you would go for HTO or UKA. But I think the population group where this works better is slightly different. That's all.
About the HTO, sir, is it the cartilage regeneration? Although there is some literature, it actually happens after the HTO, or?
So there is cartilage regeneration, but it's not hyaline cartilage. Okay. It's mostly fibrocartilage, but Cushino and all have actually done arthroscopic studies on knees, which they have done HTO on, and they find that there is some cartilage regeneration, but histologically it will never be exactly the same as hyaline cartilage.
So you have shown one slide about the fixed versus mobile bearing. Yeah. That is the difference. If you can highlight some points of that.
Sorry?
Sir, if you can highlight some points about the
That's
difference.
For Ratnesh, I guess.
Yes.
So fixed bearing and mobile bearing is the design they propose. Earlier, the Oxford, which is still doing it, still one standard. It has the mobile bearing. they have the concept that the bearing moves means anterior and posterior, and they replicate more like a normal knee. But in recent years, fixed bearing is also doing very good. One advantage of doing fixed bearing is that you can go a little, you are allowed to do a little mistakes in measuring exact gap, because if the gap is so low in cases of if your gap is high and if you put the mobile bearing which is thinner than the gap, there is chances of dislocation, and if it is too tight, it will lead to the bearing of the even the bearing of the collie, and even it also loads the lateral compartment. But this problem is more forgiving with the fixed bearing.
Yeah, so in fact, when things go wrong in a unicompartmental, the revision is almost like a revision total knee, not a primary note total knee very often, because you'll have problems of loosening, bone loss, osteolysis. And so very often when things go wrong, but having said that, there are a lot of people who are showing very good results with the unicompartmental knee in the recent literature.
So as just the last question, sir, you have already told that even in HTO, post HTO or post UKA, that TKR is possible. If we compare the both things, which one is more easier, sir?
So it all depends. I mean, it's depends on the amount of. So for an HTO, doing a total knee now is not such a big problem, because you accept that if you don't remove the implant removal can sometimes be a problem. Okay, because these are locking plates that we are using today. And sometimes the implant removal can be a problem, but the actual process of the TKR with the opening wedge osteotomy is not such a big problem. Okay? Which used to be more of a problem with the lateral closing wedge, because you had, especially if you did not correct the mechanical axis at the same time, you would have to lateralize the peg. So you needed offset pegs, etc., to do some of the total knees, or you had to or you ended up with a lateralized peg. Uni, if it doesn't have major lysis problems, is not such a problem, not such a big deal. But once you start getting that with loosening and it gets late, then it becomes like a complete revision sometimes.
So about on these things, sir, that squatting and cross-leg sitting, is it possible after uni, or is just like TKR, or we should not advise?
It is possible, but actually most of our literature came from the Western world, where people don't use to sit. The patient don't usually squat. It is not recommended, but patient can squat.
Yeah, so it depends. I don't think it's designed for squatting. Let's put it that way.
Okay. I think.
Okay.
Yes, sir. We have covered, I think, everything, all the doubts. Yeah. If any question from the DNB, you can ask directly.
Yeah. Otherwise, sorry, I couldn't make it for the whole meeting, but anyway, at least I was there at the end.
Yes, sir.
So thank you very much. And I'm sure, Ratnesh, you did a very good job as usual with the concise presentation.
Yes.
Till next week. Next week is Dhirend's, no?
No, sir, yours, sir.
Okay, mine, okay.
After that,
yes, we haven't yet decided on the topic, have we?
Yes, not yet, sir. You told that in 1 or 2 days.
I'll send it to you tomorrow or tonight or whatever.
Okay. Thank you very much, sir.
Okay, bye.
Yeah, it is great, sir. Thank you.
Yeah.
Sure.
Yes.
Good night, sir.
Good night, sir. Thank you, sir.
Okay, bye.